Good afternoon. My name is Bálint Zsombor Sárai. I would like to introduce my PhD thesis, which is Daily Aspects of Oral Medicine. I am a first-year PhD student and a clinical dentist in the Department of Community Dentistry. My supervisor is Orsolya Német, and my SMS is Kata Kelemen. My mission is to make a positive difference in all patients' life. My vision is to achieve affordable and good oral health for everyone. To achieve this, I have two ongoing projects, from which the first is investigating the efficacy of different treatment methods in Oral Lichen Planus, which will be a systematic review and a network meta-analysis. The project started in September 2023. The co-investigator for this topic is Eli Guttmacher. Regarding the pathogenesis, Oral Lichen Planus is a chronic inflammatory disease of the oral mucosa. Because of sensitivity, patients at first avoid spicy food. Later, they can eat only neutral taste food and can drink only warm water. The striae cause tension in the mucosa that makes a constant discomfort. So the disease is not life-threatening, but it reduces the patient's quality of life for decades. Over time, social anxiety and depression can also develop. Speaking of its treatment, there is no gold standard. However, topical steroids are used in the first line, but these had numerous systematic or topical side effects. Recently, calcineurin inhibitors, which reduce the concentration of pro-inflammatory cytokines, also take place. Our aim is to compare the most frequent treatments to get the most effective result. According to that, our clinical question is, which is the more effective treatment, topical steroids or calcineurin inhibitors in patients suffering from Oral Lichen Planus? Based on the PICO framework, our population will be patients with OLP. We will compare calcineurin inhibitors, topical steroids, and placebo to each other to get the outcomes of lesion morphology, severity of pain, and adverse effects to investigate the safety. Our hypothesis is that topical calcineurin inhibitor treatment has better efficiency and longer effective period than measured in topical steroid therapy for OLP. Our systematic search was conducted in November 2023 with over 4,000 results, with the search key mentioned on the slide. After the selection process, 28 articles left for the data extraction part. We have 3 ongoing analyses with the outcomes of severity of pain using the visual analog scale, the lesion morphology using the clinical scoring system, and adverse effects. The preliminary analysis focused on the severity of pain using the visual analog scale after 4 weeks of treatment period. VAS measures pain on a 10 centimeter long scale by the report of the patients. The analysis included a total of 5 studies with 3 kinds of treatments: calcineurin inhibitors, steroids, and placebo. The 5 studies included data on 275 subjects. According to Sucraplot, calcineurin inhibitors were the most effective choice, followed by steroid therapy, and placebo was the least effective in decreasing pain in Oral Lichen Planus patients. A closer look at the leak heat plot shows us that calcineurin inhibitors were the most effective choice compared to placebo, as the pain decreased 0.31. Steroids were also effective, as the pain decreased by 0.16 compared to placebo. However, these results are not statistically significant and clinically aren't relevant as well. Side effects were reported by the patients. In the vast majority, transient burning occurred during the first 2 days of calcineurin treatment period. In addition, there was no serious side effects reported. Our project has strengths of this is the first network meta-analysis. Only RCTs were included, and there are direct and indirect comparisons between treatment possibilities. The project also has limitations, such as the small sample size, from a heterogeneous population, and there are different treatment periods. According to preliminary results, calcineurin inhibitors are most effective, but as I said, there is no statistical significance yet. In addition, that placebo can also reduce pain. For the research part, our project implies that there is a big need for a universal scoring system regarding the morphology, and there is a need for longer follow-up periods. We have finished the data extraction part. Now we are working on the risk of bias assessment. My second topic is investigating the efficacy and safety of laser therapy on oral mucosal lesions, which will be a systematic review and the network meta-analysis. The project started in December 2023. Oral mucosal lesions can be complications of radio or chemotherapy or can have autoimmune origin. These lesions start to develop in an asymptomatic manner, followed by the presence of erythema, burning, and increased sensitivity. Erythema may progress to desquamation, followed by the appearance of ulcers associated with dysphagia. Because of its complexity, there is no standard treatment. Conventional therapies include avoiding certain foods, topical anesthetic, the use of topical anesthetics, topical or systematic steroids, or anti-inflammatory medications. There is a new approach that uses laser to prevent and heal these oral mucosal lesions. That's why our aim is to help patients with recurrent pain to live a quality life. Our clinical question is, how efficient is laser therapy compared to conventional therapy in oral mucosal lesions? Based on the PICO framework, we would like to compare laser therapy with no laser therapy in a population with oral mucosal lesions to get the outcomes of healing time and severity of pain. Our hypothesis is that laser therapy has better efficiency, less harmful effect, and promotes healing better than conventional treatments on oral mucosal lesions. The clinical implication is to show a better alternative with the possibility of everyday use on oral mucosal lesions. The preliminary search was conducted in 4 databases using the search key mentioned on the slide. I found 3 key articles that compared laser therapy with no laser therapy with the outcomes of lesion morphology, healing time, and severity of pain. I also found a previous network meta-analysis in this topic and no Prospero registration. Now we are working on the Prospero registry to start a systematic search as soon as we can. To mention my aims, I would like to finish my first project in September and my second in December 2024. To end my presentation, I would like to pass on a quote from Katinka Hosszú, who said, "Success is an achievement and not a final destination." Thank you for your attention.
Congratulations, Bálint.
Thank you.
Just one question regarding your first topic. How are you going to, I think it was lesion progression, one of the outcomes? No.
No, lesion morphology.
Lesion morphology, yes. How are you going to measure that? How was that measured in the studies?
Yes, there is a system by Tong Prasom and colleagues. It's called the clinical scoring system, which measures the morphology on a 6-stage long scale from 0 to 5. But in some cases, there are studies with own scoring systems. That's why I said that there is a need for a universal scoring system to measure the morphology.
But would that still be feasible to do that analysis of that outcome with the studies that you have?
We can't compare these. So.
Okay. So this is only going to be qualitative. Okay.
Yeah.
Okay. Thank you.
Thank you.
Congratulations on your presentation. My question is related to your first project. You mentioned that this lichen planus is coming with a decreased quality of life. Were there any of the studies that reported quality of life measurements? And maybe one second question, were there any other scales used to measure the pain?
Thank you for the question. There was one study that reported quality of life measurements based on a questionnaire. And sorry, your second question?
Were there any other scales used besides the visual analog scale to assess pain? Because as far as I am aware...
Yes, there were, but we can't compare these with the visual analog scale, as they use the 4-stage scale or a percentage scale. And
what about using the standardized mean difference to compare these scales?
Thank you.
I would recommend it. Congrats.
Congratulations on your excellent presentation. I would like to know, maybe you know, what is the etiology of oral lichen planus, if there is etiology, or maybe it's genetic or immune?
So it's very simple, it's idiopathic.
Oh, okay, perfect. Thank you.
Thank you.
Bálint, congratulations. And I just want to ask about the second project. You mentioned as a comparator conventional treatment, but in previous slide you mentioned various possibilities.
Yes.
So maybe if you want to compare all of them, or what's the basis of your key articles? Thank you.
So thank you for the question. We plan to do subgrouping based on the therapy regimens, because as you said, there are numerous. And that's why, if there will be enough data, we can compare laser therapy with each one separately.
And does it also, thank you very much, and does it need to be, like you mentioned in the search key, low-level laser or something like this? So this is the specific type of laser, or there is also different?
So this is a specific type of laser. There are high-level lasers and low-level lasers. And in the wound healing, we use low-level lasers.
So only this one is used.
Yeah.
Thank you.
Thank you.
So when did you decide to make this into a network meta-analysis? How did this decision come? Before or after the feasibility check?
After the feasibility check, because at the beginning we planned to do a meta-analysis comparing steroids and calcineurin inhibitor patches, but there were not as much articles investigating adhesive patches, just gels and mouthwashes. And after that, we excluded mouthwashes, and we replanned our meta-analysis, and we managed to do a network meta-analysis comparing gels and pastes.